So I'm very delighted to introduce my research collaborator, Professor Kamalan Jeevartnam of the University of Surrey. I had the surprise news yesterday that he's now the head of school at the University of Surrey. So he and I have worked together for some years now, trying to combine my sort of clinical perspective with Kamalan's rather more scientific approach to the whole thing. Kamalan.
Thank you very much for the invitation and to the Trust, as well as the memorial to Jared Lee for this invite. So what I'll be talking to you basically is just about a brief approach to using artificial intelligence in trying to predict and read ECGs, and how can we try to improve what we do in practice. So somewhat what I often say, sort of clinical risk stratification. How do you stratify your patients and decide, you know what, where do I spend resource most to try to identify horses that are at risk and that probably need better surveillance, better monitoring, and those sort of things. So I have at this present time for this particular work, I have no financial disclosures to make or any unapproved use for it. What we will be talking about specifically is in the context of paroxysmal AF. So we know that roughly about 10% of race horses in the UK have an event that's related to cardiovascular. They're mostly athletic horses, and the symptoms are poor performance generally, shortness of breath, and intermittent periods of irregular heartbeat. Now, diagnostics are typically opportunistic, auscultation, and then subsequently you confirm it by an ECG if you get to catch it. So it's almost like, catch it and then you can make the diagnosis. If you don't catch it, you can't really make the diagnosis on an ECG to confirm. Obviously, treatment, as we all know, would be cardioversion. This could be either chemical cardioversion or electrical cardioversion, depending on what is required if there is a need for it. The human perspective as well is AF is a major cause of stroke. Obviously, stroke is not something that occurs in horses, but the key fundamental issue here is that most of the time the drive is to make the prediction that an individual has a PAF episode, because only then can an individual be put on an anticoagulation therapy. If you can't diagnose PAF, you cannot simply put an individual on an anticoagulant therapy. So a lot of work in human AF is geared towards trying to predict as soon as possible. If someone comes in, they report palpitation, you put on an ECG, you don't see anything, it's all sinus rhythm, you can't make a diagnosis of PF. You put on a Holter, 72-hour Holter, you often don't see it because Holter sensitivity rate, and I'll talk about it, is about only 20 to 22% it can detect. It's very specific when it picks it up, but it's not very sensitive because it takes a very long time to get the reading and to pick up an event. So there's a huge drive, even in human medicine, to try to predict individuals that have had PF episodes by actually looking at their sinus rhythm ECGs, and that's what we're doing here. So again, you've probably heard about this, the electrical activity of the heart, and just a reminder, you have what we call the systole part of it and diastole, which is the relaxation part of the heart. And what really we are trying to do is that we're trying to follow through this entire electrical process and trying to see what actually is going on in this particular system, and trying to identify events that are not discernible to the human eye. So often an ECG is interpreted, you get an ECG, the cardiologist looks at it and says, looks fine, no issues, this is normal sinus rhythm. But we fundamentally believe that there's something else, and that's really where the clinical question is. So what we were asking is, how do you identify individuals that have a rhythm abnormality that occurs intermittently? So you don't really see it, but we know that it may be there, and we're not just catching it. So I'm an electrophysiologist as well. I've trained my PhD in cardiac electrophysiology, and we fundamentally know that horses that have PF may have what we call background electrical abnormalities. And we can't see those electrical abnormalities. But if we can't see it, can we get a computer to look for it for us? And can we train the machine to identify these background electrical signals without us having to do it? So obviously the idea was based on mechanistic understanding, electrophysiological mechanistic understanding of how AF occurs. Can we develop and validate computational algorithms to help us identify by reading and understanding, analyzing sinus rhythm ECGs? Now, what I will do here is I'll talk to you about very quickly about 3 algorithms that we have developed, of course, in the group. So there are 3 different algorithms, and sort of take you through the process at which we were thinking how they work and why did we pursue each of them on a step-by-step basis. So we first had that main question about, you know, can we train a machine and can we get the machine to do it for us? But it seemed quite, you know, is it really possible? So in order to prove that first, we needed to first do what we would call, does the method of developing computational algorithms actually work on equine ECGs? Forget about even detecting AF. Does it even work on equine ECGs? And that's the first question we asked. So we talked about the first algorithm that we developed, which is called complexity analysis, which actually is, to put it very simply, it's just maths. It's just a range of different mathematical formulas all assigned together and made automated so that it can read the ECGs. It breaks down the ECGs into binary strings, 1 and 0. So what the maths does is takes the ECGs, breaks it down into 1 and 0 formulas, and then sort of grains it into different levels. And that's what it does. It's reading the whole entire, from the systole to the diastole. It's reading every electrical signal on it, converting it to 1 and 0s, and feeding it into the computer. And that's what complexity analysis is doing. And we said, let's try to apply it on equine ECGs. And we applied it, and we said, you know what? These maths and these formulas can actually apply. And we published a paper to say that, look, it does work. We can apply this. So these were control horses, perfectly normal, no cardiac rhythm abnormalities as far as we are concerned clinically. And we just applied this algorithm and said, it works, so we think we are onto something here, that we can at least use it as an experimental protocol to try to differentiate between case and control. So then we went on to then recruit control horses and PAF horses, and then apply this complexity algorithm to see whether this particular algorithm can differentiate. Now, what the algorithm here is doing, it's looking at perfectly normal sinus rhythm ECGs from all these horses. So we got the normal sinus rhythm ECG from a PAF horse, and we got the normal sinus rhythm ECG from a control horse, so they're identical for all intent and purpose. So the clinicians have said, these are all normal sinus rhythm ECGs. And we then put it through the complexity analysis machine, and the machine then tells us which one has had a PF episode. So by analyzing just their sinus rhythm ECG, the machine is predicting that this particular horse has had a PF episode previously. So what it does is that it's possibly reading a lot of background electrical signals, the binary strings that's being converted by the machine, shows differences between purely normal sinus rhythm ECGs and sinus rhythm ECGs that come from horses that have had a previous incident of PAF. What we're detecting here is that using 2 different types of complexity method, you would see we're getting an area under the curve of about 95% and 90% accuracy rates in this particular study that we did. Of course, this was not a blinded study, so our data scientists were exposed to the actual outcomes for the horses. We required them to be exposed to it, and we felt that, you know, that's the only way they could build the maths around it and the systems around it. We did then run a single-blinded case control validation study, so all the data scientists that were working on it were not told, they were just given a dump of ECGs. Can you tell me which one it is? They just had to put it into the machine and come. And then we have obviously got, using 2 different types of complexity analysis, you see one at 89% and one at 98%. So this is a very small cohort of studies that we had just to validate. So we're getting onto something. So that's the first algorithm that we tried. We then went on to do the next one, which is restitution analysis. So restitution analysis, what it does, and if you, what Celia mentioned is, you talk about when AF occurs, it tends to occur in the situation where the horse is racing and it comes back at rest. There's this mix of the CNS telling, you know what, stop, reduce your rate, and the adrenalines are there. What restitution analysis does, it tries to study how the heart copes with varying demands. So it's about trying to understand, can the heart reduce its rate in conjunction with the requirements of the system. So it's trying to look at how fast the systole time, the time of contraction, and the time of relaxation are reducing and increasing. Do they reduce and increase in tandem to the need? So it's trying to look at the ability of the electrical events to compensate for each other. And that's what restitution analysis is. So we actually identified different, so TQ, QT intervals, RR intervals, so all looking at the systole and diastolic phases in the ECG, and then we plot them across a three-dimensional graph, and we try to understand whether they are failing to compensate adequately, or whether they're actually, following a perfect trend of how physiologically heart should be performing. Again, the question came, can you actually use this on equine ECG? Are you just simply throwing something on an ECG? So we went back again straight to the whole thing. Let's prove first whether we can apply restitution analysis on just normal equine ECG. And we went on to publish a paper trying to say, yes, it's possible, it's entirely doable, it's not something that we're just throwing mats into ECGs. We then subsequently went on to use the same cohort, and we developed a machine learning approach using restitution analysis, where we build this cohort, and what we did conclude is that if you use 3D ECG restitution, you can use it as a metric to automate the detection of paroxysmal AF by just analyzing sinus rhythm ECGs. So throughout this entire process, all algorithms are only looking at sinus rhythm ECGs. They are not looking at ECG traces that are AF, that you can diagnose by a clinician. They're only looking at purely sinus rhythm ECGs. Okay, so that's the next one. So what we've done is that we've now shown that the next algorithm that we have also can mimic and can identify, help us detect PAF by just analyzing sinus rhythm. Then we went to the third one. We said we've got access to a third technology that we have developed in-house, and that's called symmetric projection attractor reconstruction analysis. Don't bother about remembering that, it's just called SPA. And we did the same thing. We tried to identify, can we use SPA as a method? And what SPA does is SPA is slightly more interesting. It takes all the points, the data points in a particular ECG, and it draws a star. Okay, it draws a star, and what it does then, it tries to analyze the star and try to identify whether the shape and the picture alters. Now, this is important not so much for AF, but it's important actually when you think about it if it's used in complex rhythm abnormalities and in ICU. Because what you can do is you can put SPA on a monitor, and your clinician or your ITU in humans and intensivists can look at the shape of that star and make a diagnosis whether that patient is having complex ventricular rhythm abnormalities or complex rhythm abnormalities by just looking at how the stars alter, and so it's very dynamic in its flow and how it starts changing. So there's a lot of work going on in this in human medicine as well. So that's one of the approach, and we decided we're going to apply it and see whether we can use it in equine ECGs. And yes, we did, and we did prove it. So now you have all these three algorithms, and one would say you're dumping algorithms and you're trying to find whether they work. And in a way, yes, you're right. We're trying to do a bit of that. But the question here is all these algorithms do give us some level of prediction, and every algorithm has their own preference, and every algorithm has their own detection methods. So the question we often ask ourselves is that they seem to give us good to excellent, so which one do we pick? Do we pick restitution? Do we pick complexity? Do we pick SPA? Which one is better than the other? And we don't have the answer for it. That's the honest truth. So one approach is that, can we use something called assemble analysis? So assemble analysis is an approach where you almost develop a machine, and when I say a machine, meaning it's like an AI technology and a platform where the machine assembles the three different algorithms and draws a decision tree. So it takes complexity's decision, it takes restitution's decision, and it takes SPA's decision, and it predicts who has the stronger power. It has the game between all three, and the machine, the assemble analysis, then comes up with one final decision. So you imagine a tree with all these three algorithms, and the tree has a game around it, and then finally you come up with one decision whether this horse is at risk or not at risk. And that's what we're trying to do. So the part of the work that's going on now is can we combine this using assemble analysis and try to create a decision tree using the machine. And that's what is happening. Now, there is one fundamental question that we're not able to answer. Well, it's not that we're not able to answer. We haven't had enough funding to pursue the basic science component of these answers. It's often people turn around and grant reviewers turn around and ask us, what are you looking at? What is that system? What is that algorithm that you're doing looking at? Is it looking at the P waves? Is it looking at the duration of the P waves? It is looking at the shape, and we don't really know that answer. And you can reverse engineer the work, and you can try to do that, but that would take the data scientists years to reverse engineer the technology and to untangle it to find out what exactly is that machine detecting on that ECG. Now, it's a great academic question, but clinically and from an application perspective, we need to move forward to try to get this into practice. Because we know it works, we now need to validate it. And like all algorithms, they're all very hungry. So data hungry, and the more we have, the better we get. So what is really important to this particular work is running multi-center trials for it. So ultimately, the aim is that what we would like to do is we would like to have neural networks, which are these decision trees. And can we then input clinical data? Can we then put in omics data? So looking at multi-omics, transcriptomics, and feeding it into the system and making the predictions much more stronger. And can we then actually use this data more reliably in practice? And that's really where we're trying to go. But clearly, without even having to go there, complexity and restitution are already proving to be very useful from a clinical perspective. So coming back to techniques and why I say it's important, in human medicine, if you look at Holters, and if you look at this particular graph, what you see here is that it takes quite a long time to make a prediction. So you're looking at anywhere between, even at 30 days wearing Holter monitors, you're looking at perhaps predictions going up around 90, but no one wears a Holter for 30 days. If you go to a cardiologist in the NHS, they'll give you probably maximum 72 hours, or if not, they'll put in a loop recorder for you. So it's going to take a lot of resource and a lot of money for the NHS to be doing that. And likewise, even in veterinary medicine, we can't put a Holter on for 30 days to kind of get that kind of accuracy. What we are trying to do is we're trying to operate in, can you give us just 1 hour of recording, and we can take you even up to 70 to 80% accuracy and give you a prediction. And that's where we're trying to operate, and we're trying to move the paradigm in this diagnosis and Holter monitoring or long-term monitoring of predicting intermittent cardiac events. So what we want to do, we know that it works. We know nonlinear analysis like complexities and restitutions do work. Our future plans are, can we do full-scale validation and optimization? Can we explore complexities, the links of complexity and restitutions? The feasibility of AI, which is assemble analysis, which thankfully is being funded by the HVLB, and also genomics and proteomics work. We're very fortunate that the Hong Kong Jockey Club Welfare Foundation is supporting us on the genomics and the transcriptomic work over 2 years to grow that information and grow that database for us. And ultimately, we want to create a resource to facilitate AI-based aspects in veterinary medicine. We are fortunate also that we've got a grant from the UKRI, which is about scaling up innovation. So what they're trying to do is support us to build what we call a minimum viable platform, where hopefully we can, once we've developed it, is to automate a back-end process where clinicians can submit ECGs onto this online system. It's automated, and it analyzes the ECG, and it gives the clinician back a prediction. So that's about scaling up the innovation that we're trying to do. But I come back to the next concept of one health and one medicine. So going from what we've done in equine medicine, we have also now, after having to convince the Medical Research Council, this is probably the only veterinarian-led NHS trial that's going on in Liverpool Heart and Chest Hospital, as well as GP integrated services, where we're looking to transfer these algorithms that we've developed into the NHS, looking at PAF patients in hospital in this NHS setting and trying to use the algorithms, and this being funded by the Medical Research Council. So we have primary outcomes as well as secondary outcomes to try to determine whether these algorithms actually do work. Lastly, I just want to end with the concept of artificial intelligence in clinical trials. I mean, you would have heard recently in the BBC and a lot of news where the Facebook head, Elon Musk, and Google AI all commenting that AI will destroy humans and AI is not good. And fundamentally, AI in medicine needs to be regulated. And at the moment, there isn't strong regulatory processes like the MHRA that looks at how AI is used in practice. And if you imagine, every day my data scientists are changing the algorithms. Every day they get an ECG that gets fed into the system, the maths changes. Now, if I'm rolling out in practice an algorithm, what is my responsibility to inform regulatory authorities that I've changed the algorithm? Because if I'm changing the algorithm by the day, because that's how the machine is learning, every day the machine is learning and it's changing its approach and getting better, how do I report that change and ensure that I'm being monitored if I'm using something in practice? For example, if a drug is improved, you make a report to the MHRA, you release the drug improvements and you do that. But you can't do that in AI because it's so, what sort of framework that we need to operate on when we start developing AI technology? So there is a need for stewardship within this area. So there's huge demand for AI stewardships and its practice. How do you regulate? When do you use it? How do you develop algorithm inventories? So you need to be reporting the inventories of all your algorithms, and every time it changes, you need to update the inventory, and that inventory should be accessible to regulatory authorities. So there's a need for stewardship. But more importantly, there's also a need for trust from end users. And this is an example of a study where they had an AI and a machine learning about trying to predict out-of-hospital cardiac arrest in Denmark. So what happened here is that they had dispatch callers who would listen to a conversation, speak to a person over the phone, and make a decision whether that event is a cardiac arrest, and then send an ambulance out for that particular individual. That same telephone conversation is then put into a machine, and the machine then makes the decision whether an ambulance needs to go out or not. And the machine predicted cardiac arrest far much more accurate than the dispatch caller. But the dispatch caller refused to recognize the machine's ability to predict who was in cardiac arrest and whether that call required an ambulance sent out. So there's also an aspect of trying to build trust in trying to understand how you use these algorithms, how you build and develop it. And that's the other part and aspect that we need to also start developing going forward. So I'm very thankful to the DREAM team. These are the individuals who have been helping me a lot. Vet Partners Group, British Horse Racing Authority, Sally and James for all the support and data. The Hong Kong Jockey Club, the clinicians at the Hong Kong Jockey Club, who's been very enthusiastic and very supportive to try to get us data and support us meticulously in providing the information that we need. We do have Singapore Turf Club as well on board, and the University of Minnesota, who's collecting 500 ECGs across the racing jurisdiction in that region. And of course, to my funders, the Engineering and Physical Sciences Research Council, HBLB, Hong Kong Jockey Club, Pet Plan, and the Grayson Foundation. Thank you very much.